Alright guys, so when you're watching this, you're going to be checking out the first session we're having. A few of you guys might start joining right now. Currently, at the point where this class is starting right now, this is the first time I'm doing it. So thank you very much for being a part of it. I hope that this will help you all to the best that it can. And I'm going to try to give it my all, of course, as always. Teaching has always been a passion of mine. For those of you that already know me, welcome back to my tutoring services. And for those that are new to finding out about me, my name is Amir Malik. I'm a medical graduate living in New York and looking forward to applying for residency this September for the first time. Trying to go into internal medicine and in the long run eventually become an interventional cardiologist. So that being said, yeah, cardiovascular definitely is one of those topics that I am very comfortable with. I have a lot of rotation experience with that, as well as a lot of experiences just in general from studying and doing practice questions and so on. I've also been part of many research moments ever since I started working as a clinical research coordinator here in New York at Montefiore Hospital. So there's a lot to know. There's a lot to know, and cardiovascular is one of those topics that on your CK exam will pretty much be a part of every single patient, just like the cardiovascular system will be a part of every single patient that actually comes into the hospital, right? Whether a patient is coming in for a general procedure, whether it's a GI procedure or a reproductive procedure, whatever it might be, almost every single patient, I can say confidently that practically 100% of patients require a cardiovascular consult, right? An evaluation by a cardiologist upon admission. All right. So, when a patient comes in, you have to check their vitals, you have to check their cardiovascular function, and then when you prescribe the medications, you have to make sure that these medications will not interfere with other cardiovascular medications they might be on, whether it's directly for the heart or medications that are related to blood pressure, medications that are related to actually managing the overall endocrine system, such as diabetes medications, other endocrine disorders like thyroid disorders, right? So you have to make sure that all of these things come together because, for example, the thyroid itself is something that's related to the entire body, right? It's quite a metabolic hormone that affects more than one system. So on quick glance of this versus, I also have here the first aid for step 1. So let's take a look at both of them. Just for their contents together. So they don't have the contents page for first aid for step 1, right? Like this. They don't have something like this on step 1. But pretty much everything that you're seeing here on the contents page of first aid CK, bradyarrhythmias and tachyarrhythmias, congestive heart failure and the different types with, ejection fraction being reduced in the systolic version versus being preserved in the non-systolic or diastolic function version. Cardiomyopathy, right, dilated, hypertrophic, or restricted, coronary artery disease, acute coronary syndromes, the different dyslipidemias, which were mainly discussed in the biochem chapter of first aid step 1, hypertension, pericardial disease, such as pericarditis and cardiac tamponade, the various valvular heart diseases, and then of course, vascular diseases that can occur, and syncope. Nothing here is brand new, right? So literally all the different disorders and problems and interventions that are being discussed here for the most part are things you've already learned about and visited in first aid for step 1. So the one new thing here that is going to have more focus is going to be the ECG. They're going to talk a lot more about it here in step 1. Most step 1 students that I've ever worked with, I've never had one that actually confidently told me they know how to evaluate an ECG, they know how to work with one and figure out exactly what's wrong or have a top 3 options on what's possibly wrong with the patient that comes in upon being given their ECG. So you have to know the ECG extremely well when it comes to CK. Other than that, most of these other topics that are here, we're going to go through them. They're not so bad, and we should be done with all of this by our next session. All right, so today's session, let's get this started here. So first things first, the electrocardiogram. Now, throughout first aid CK, you're going to have these mnemonics that are mentioned and some key facts. This is the design of the first aid CK, right? So first aid step 1 didn't have that. They didn't have things on the sides that were key facts or mnemonics. So that's something nice that they have in first aid CK. Definitely worth utilizing. And the mnemonics that are given are almost something that you will uh, definitely be memorizing and utilizing. All right, so they go on to begin first with talking about the rate, rhythm, and access, the three main components of what you're going to learn when you're looking at an ECG. So now, if you've never really actually performed an ECG on a patient, you want to go ahead and check out a YouTube video where you see it being done, right? So there's going to be some video you have to find where they put the various leads on the patient. You're going to learn about where those leads are being put, whether it's on the left arm and right arm, where across the chest they are, and so on. And then you're going to see how the ECG is being actually performed physically within the clinical setting, right? Then you have the strip. You get this entire strip, and when you look at an ECG strip, it's one of those things that is very similar to like reading. The more you read, you've been reading ever since you first started school, and possibly even earlier, like in preschool. The more often you read, the better you get at it, right? And this is also one of those things that you, as soon as you look at it, you're going to have a pretty good idea of what's happening in here, what the data is here, and then you're going to be able to evaluate it, and you're going to know how to read it. That's the other thing you need to know. So rate, normal adult heart rate is 60 to 100, right? Under 60 is slow heart rate, over 100 is too fast. So that's what they tell you, bradycardia under 60, tachycardia over 100. Common causes of sinus bradycardia, which means that your sinus node is the one that's actually causing you to have bradycardia, are things like physical fitness, sick sinus syndrome, drugs, vasovagal attacks, and an acute MI, as well as increased intracranial pressure. These are all different scenarios that we're going to be visiting. Throughout my annotated first ACK, what you're going to see, besides the extra images that are there to help you tie things in, are going to be the occasional randomly, not actually randomly, perfectly placed UWorld questions, right? So those are, here specifically we're seeing AMBOSS questions. We're also going to see oftentimes, I label the AMBOSS ones as AMBOSS. If it's not labeled, then it's a UWorld question. So here there's a UWorld question right there. So these questions are actually placed according to what's been discussed. And occasionally I'll also add blank pages to which I put the entire CK page there, right? So that's something that you want to make sure you grasp. That being said, let's come back to the top. Okay, so that's your rate topics, right? Common causes of sinus tachycardia, things that increase your heart rate, are going to be anxiety, anemia, pain, fever, sepsis, congestive heart failure, a lot of things, right? So CO2 retention, another one of those, basically acidosis, and sympathomimetics, things that act like your sympathetic nervous system, which is for fight or flight. Rhythm is basically how repetitive it looks, right? So rhythm is basically, it should have the same tone to it, right? There shouldn't be a lot of jumping back and forth and changes in rhythm. Normal rhythm that originates from the sinus node is what you're looking for. It is characterized by a P wave, which is going to be upright in 2-3 in AVF, and inverted in AVR, right? So we're going to memorize these things and learn them over time. You're just getting started, then it's okay. You might not have known this when you were reading this, but now you will, and I'm going to talk to you about that more soon. So a P wave preceding every QRS complex, and a QRS complex following every P wave, right? So there should never be a P wave without a QRS complex after it. That should never happen. Sinus arrhythmia is common in young adults. It's not always pathological either, but arrhythmias in patients who are, I would say, 35 or above, even 30 or above, that's pretty concerning for what might be possible atrial fibrillation or something. The axis, this is something that most Step 1 students have no idea of. The axis can be determined by examining the QRS in leads 1, 2, and AVF. So the axis is something that you're going to see later on. It's going to become more clear as you go into the studies of the ECG more. So we're going to see, like, these are the various axes here. But let's actually dive into this, right? So let's look at this blank ECG over here and assume you were given an ECG, right? So here, this is your normal ECG. Let me grab my pencil. So this is your normal blank ECG from a healthy subject. And of course, different ECGs you might get that are pathological might have different presentations, of course, right? This is only going to be true for a normal patient, and for other ones, you're going to have other things that you heard of in Step 1, such as ST elevations, ST depressions, mess up rhythms, right? Or you could have fibrillations where you have too many P waves, or the flutter sign, and so on and so on. Okay, hi Omura, nice to have you here, man. I've already started recording it, so don't worry if you missed anything. It's all going to be online. as soon as I post this there, but we just got started like 12 minutes ago, so not much was missed. I was just talking about all the things that are happening in first aid step 1. Hey, how you doing, man? So good to have you there. Just and feel free, as always, for even those watching the recording later on, if any of you ever have a question while I'm lecturing, you can always go ahead and just send me a direct message, and I'm always glancing over to take a look at my other monitor to check for that. Alright, so let's get into this. So we have this blank ECG. What are things you're going to look at, right? So these are some of the things we're going to be talking about right now as we go on. As soon as you get an ECG, the first thing you should do, assuming that it's in standard format and it's not something bullshitty that a step people made up, you want to divide it in half. You want to cut it in half right here, right? Such that you have your 1, 2, 3, AVR, AVL, AVF on the left half, and then you have your V guys, V1 all the way to V6 on the right half. And one of the quickest things you're going to want to make sure you glance over really quickly is something called the R wave progression. Right, so R wave progression. R wave progression is something that's going to be discussed pretty soon. It's coming up. But when we get to that, you'll see it. But right here, I can show you what R wave progression is. So R wave progression definitely, obviously, refers to the R of your QRS. Right? So if you have a general ECG, you're going to have the P wave, you're going to have your Q, R, and then S, and then a possible T. Right? So those are the things that happen. So this is your Q here. This is the R on the top, and then the S. Great, so that's your standard stuff you're looking for when you have your ECG complex. So the R wave progression is something that looks at the R wave in 1 through 6 to see the changes. As you can see when you first start looking at it, the R is very tiny in V1, okay? Then in V2 it becomes bigger and is pretty even on the top and the bottom. V3 has got an even taller R wave. V4 has the tallest R wave, and then you can see how it's starting to, progressively change, right? So now by V5, the R wave is entirely on the top and nothing under the baseline. And then by V6, it becomes a little shorter again, right? So there's this really nice R wave progression that you're going to want to look for from beginning to end on the right half of this ECG. If you have a patient where you cannot see the R wave progression, then you can already see where the leads are here. Based off of where the R wave progression is messed up, it's going to be one of those leads, and then, of course, respectively, one of those blood vessels that are messed up, and that's how you'll pick your answer. Of course, there might be other things involved too. We haven't looked at everything yet, but that's the general beginning, right? So this is basically a how to read ECGs. So that's one thing you're going to look for. And we're going to talk about the R wave progression coming up pretty soon as well. This is another image here showing you the R wave progression, right? So you can see how in V1 it's down, and then it's slowly coming more up, right? And that's your R wave becoming taller as you go from V1 to V6 in this image down here, okay? So I roll here in the normal ECG. V1 starts at a net negative, and this progresses to a net positive in V6. Lead V3 is often equiphasic, where it's going to be equally as tall on the top and equally as tall on the bottom, right? So that's why it's equally as positive and negative, equiphasic in V3. The R wave gets longer from V1 to V4, and that's that slope you're seeing right here. And then it gets a little shorter after that. So that's your good, normal, healthy R wave progression. Other than that, the other thing you want to quickly always look at is your 2, 3, and AVF, right? So you have your 2, 3, and AVF, this area right here. Okay, in first aid for step 1, they have this image to help you start seeing that as well, highlighted in pink, which looks at this bottom area. Right, so in first aid step 1, they have actually now kind of sort of started mentioning the axes and things. They don't really talk about it too much, but they have these images that are actually showing you axes, right? So what you're seeing here is an axis of the heart. 2-3 AVF is actually really critical, mainly because of the arteries it looks at, right? So it looks at your right coronary artery and your PDA. So if you haven't refreshed that in quite some time now, you want to make sure you go back to first aid step 1 and check out the cardiovascular anatomy, right? So first aid CK, one of the flaws it has is that it's assuming you're done with step 1, and it's also assuming that you have pretty good recall of everything you did in step 1 studies. Right, so you want to make sure you know the arterial supply and the anatomy of the heart. know where the blood vessels go, and also know the nodal supply, right? So here is just a quick revisit of that, where you can see your RCA is the guy that supplies your SA node, and this is actually dependent on a couple things. So the RCA supplying the SA node is fine. That's never going to change, right? Right coronary artery itself directly provides blood supply to the SA node. So that's right here. Okay. Then you have your PDA. Your PDA is supposed to supply the AV node, but the PDA is dependent on your circulation dominance. Whether your PDA actually comes off of, as we see in this image here, they're showing you the PDA is coming off of your right coronary artery, which is yellow, right? So you have your yellow-orange right coronary artery and the pink PDA. What can happen, though, in a small but significant number of patients is that your PDA might actually arise off of here and go like that. Instead of this purple line, you would have something like that, right? So then at that point, you would have left dominant circulation where it's coming off of either your left circumflex, or you're going to have something co-dominant, right? So left circumflex right here could give you the PDA like that. That happens in what they say about 8% of people. So that's a pretty significant number of people. Either way, right, although your RCA is the guy that will always supply your SA node, who supplies the AV node is dependent. However, in majority of people, 85% of people who have right dominant circulation, your right coronary artery is the one that will also be supplying your AV node through the PDA. Okay, so the PDA supplies the AV node, but you have to figure out where the PDA is coming off of. Is it coming off of the RCA, or is it coming off of the left circumflex? However, since for 85% of people, both nodes are supplied by the RCA, you really care about what happens to the RCA, and you care about what happens to the PDA. So thankfully, 2-3 and AVF actually look at both arteries at the same time, essentially, right? So this is going to actually check for an inferior MI and check for whether these arteries are involved, because if they are, then that would also imply that you're not going to have good supply to the SA and AV nodes, and that's not going to be very good for you. So you would have to then go ahead and this will tell you how to further evaluate the patient in terms of treatment. The yellow and the red is basically showing you exactly where the leads are placed. So if you do perform an ECG on a patient, when you lay them down, the V1 and the AVR are the only things that are going to be on the right side of the mediastinum. You're going to put the V1 pretty much right next to the right nipple, and AVR goes on the right hand. So those are the guys that are on the right side. Then V2 through V6 are all going to go on the left side, basically encircling and going under the left nipple. Right? So starting from right next to your, in between the left nipple and the mediastinum, and then going under and around your the left breast and the left nipple. 2, 3, those go on the legs, and you're going to have your AVL, left hand. So these are all the different places these guys are being placed. And what happens is that the placement of these leads, as I was saying in the beginning, to make sure you check out a video of the placement of these leads is partly the reason why a lot of these lines either go up or they go down, right? So here they just told you that you're going to look for a P wave that is upright in 2, 3, and AVF, right? So in 2, 3, and AVF, you should have a P wave that goes up, right? You're seeing it. It's all there. You don't have a P wave that's going down. It's not a very prominent P wave, but they're there. They are there, and they are pointing up. And so there's a reason why lines go up, and then you can see where things are going down, actually, right? You can see in AVR, the whole QRS is pointing downwards. In V1, it's all pointing downwards. And then everywhere else is pretty much either equiphasic or pointing upwards. So AVR and V1, the clear, obvious thing that's pretty unique about them is the fact that they're on the right side. Okay, AVR and V1 are on the right side. 2 and AVF, these two you don't really want to consider too much in this aspect because they're really far away from the heart, as opposed to AVR and V1. They're pretty close to the heart. Even the one on the right hand, and anatomically speaking, it's far from the heart, but functionally speaking, it's pretty close to where you would feel things, the pressure of the heart coming from. And the way the electricity is read depends on the way this heart is actually facing. So since your heart is facing to the left, and since most electrical impulses are going to come from this area right here, where your SA and AV node roughly are, all of those impulses go in this direction. Right? So they go in this direction. So since those impulses are going in those directions, the line tends to only go up if the impulse is actually going in the same direction as where the leads are. Okay, so since it's an impulse that's going away from AVR and V1, those guys have a ECG complex pointing downwards, right? So it's backwards, and that's the only reason it's pointing down. So that's the basic understanding of why some of these lines even point up and down, and you'll never have to really memorize that because you'll know that now. You'll know that the lines are only pointing up and down based off of whether or not the electricity is actually traveling towards the lead, right? For AVR and V1, those leads are on the right side and the electricity is traveling away from them, so those leads point downwards. Now, right off the back, for axis deviation, something that will be something you can have in your answer choices, you have a mnemonic, right? So you have this Rad-Ralph mnemonic and the Lad-Villa, okay? So Rad stands for right axis deviation, Lad stands for left axis deviation, and the mnemonic is just here to help you understand what are possible etiologies that might have caused a right axis deviation or a left axis deviation to occur. These things were actually happening in most of your step 1 questions also. They were happening, they were just never really referenced. In fact, it's very much possible that you might have had a step 1 question either on your own step 1 or Kaplan or UWorld where they mentioned in the question stem a right or left axis deviation, but it wasn't something you were being tested on. It wasn't something that you had to pick as an answer choice. Right? So you have your right axis deviation, which could be due to right ventricular hypertrophy, anterolateral MI, or a left posterior hemiblock, which can also be something related to a pulmonary embolism. Right, so these are all your different scenarios that fit into the mnemonic of Ralph. Villa is for your ventricular tachycardia, inferior MI, which is going to be related to the blue area here, left ventricular hypertrophy, or left anterior hemiblock. Okay, so all of this also very nicely and appropriately fits into the Villa mnemonic. Wolff-Parkinson-White syndrome can cause either one. So at that point, if you're evaluating a patient for Wolff-Parkinson-White syndrome, right axis deviation or left axis deviation would not help you make the diagnosis because neither of those things is specific to any one of these things, but neither of those things are really specific to Wolff-Parkinson at all. Right? A patient with right axis deviation might come in and you might see the right axis deviation, but you won't know for sure what they have. Is it a right ventricular hypertrophy? Is it an anterolateral MI? Is it a PE? You'd have to do more management to figure out more evaluations, more tests need to be ordered, right? And that's kind of what your CK exam is all about, which test you should order next. And that's something that you have to get really good at because although on the surface it seems like it's a pretty simple question, you know, what test should you order next? Well, if a patient came in with certain symptoms, obviously it's going to be very straightforward what test to order. You're going to quickly see when you start doing questions that there are often going to be some of these UWorld questions for CK where it's a 50-50 thing. 50% of people might have picked answer choice C, another 50% picked answer choice D, and the reason it happens is because both tests were actually viable things to order for that patient's diagnosis, but one of them were a better test to order than the other simply based off of you knowing somehow what was more likely. Okay, and that's where you have to, by practice, get better at. So then they go on to kind of break this down a little more and obviously make it more confusing. So you get the mnemonic down to figure out what could have been complications. Then they have these arrows. So your normal axis is supposed to have the up for lead 1, 2, and AVF. So you're looking now at 1, 2, and AVF. 1, 2, and AVF. All right. So those are the guys you're looking at to create an axis, to see what the axis deviation is. Right. If you look at this pretty much a compass in a sense, this is where they break down the axis information for you. This is how you create axes for a heart, okay? It's also based off of the same leads that you've been looking at, so you have your different leads actually being placed onto here. And your general 90-degree angle is actually going to be this area right here, okay? This is your normal QRS access area. The normal QRS goes all the way from AVL to AVF, okay? But the 90-degree area is here, okay? So this entire orange area that they've highlighted is your normal QRS access. That's normal. That's anyone that's okay, doesn't have any kind of pathology, no problems whatsoever. The right axis deviation stuff, which was your Rad-Ralph, all the Ralph mnemonic things, those are guys who have things that are causing more impulses to be on the right side. Now, you could have more impulses on the right side for multiple reasons. One of the Ralph things were actually your right ventricular hypertrophy. If your right ventricle is stronger and more meaty than your left, you're going to have a deviation towards the right side because you're going to get more impulses on the right side. The other thing that can happen is your left side just doesn't work. Right, so left posterior hemiblock is listed here. If the left heart is just weaker, then automatically your right side starts becoming stronger than the left, and then on your axis deviation, you're going to see right axis deviation. You're going to see things that are moving towards the right side. Right? And then the same opposite of things is true for the left axis deviation. It's very rare to have left axis deviation. It's not a common scene at all. But one of the most common things that can occur is just the inferior MI. If you have an inferior MI, you could get a left axis deviation, because that would mess up pretty much 2 to the AVF, so you would mess up all of these guys, right? As you already know from what we just talked about for this blue area and what we're talking about evaluating ECG. So if someone has an inferior MI, that would mess up this area, and more power would essentially be shifted towards the left, making this axis, this normal axis from here to here, would actually shift in this direction so that the normal axis would become something like that. And so it's a very... Honestly, this is a very complex thing that you don't really need to know very, very well. The only thing you need to know is how to pick that answer choice, right? Getting good at axis deviation, figuring it out and stuff like that. There's a lot of images here to help you kind of see that and look for things on your ECG. Always you're going to be looking at things for 1, 2, and AVF. Those things are things that will come with practice, and you'll get there when you get there. For now, you want to make sure you understand why an axis deviation even occurs, right? So we get that now. We understand that things are going to have a right axis deviation if the right is stronger than the left, either because the right is stronger or the left just became weaker, and vice versa. Now, how do you catch that on an ECG? So that's what this table is here for. If you have a patient with left axis deviation and you look at leads 1, 2, and AVF, lead 1 will be the only one pointing up. Okay, lead 2 and lead AVF are going to be pointing down. That's somebody with a left axis deviation. So if you have this image memorized, which generally speaking isn't so bad because this is actually the same image as what you see here. It's the same stuff. This image is basically the axis circle being put onto the heart, right? So that's exactly what you're seeing right here. So for the most part, most people do have this image memorized, and with a little more effort, you can actually have it memorized pretty solidly. So what you're seeing is if somebody has left axis deviation and things are moving in this direction, then this and this must not be working too well, right? And that's what we're talking about. What we're talking about. Wait, I crossed out the wrong guys. This and this must not be working. Right? So 2 and AVF are pointing downward. They're not working too well, and things have shifted towards the left, right? Because you see how your normal axis incorporates AVL, 1, 2, and AVF, right? All 4 of those leads. So now if things have a left axis deviation, it must not be on this area anymore, and things shifted up. So if I change the color of this pencil just for common purposes, let's see, and then I pick something like, oh, here we go, like this blue. So now the new shift would be something like that, right, where it moved over that much. See, so now it's not really using 2 and AVF that well. More electricity is going in that direction as my original red arrow. So you remember how if electricity is moving opposite to where the lead starts pointing downwards. And this is why 2 and AVF will now, in a patient with left axis deviation, leads 2 and AVF will start pointing downwards, right? So very important to grasp that, very important to make sure that makes sense to you. And you can see that in the extra images I put here. So this one here on the top is showing LAD, left axis deviation, which is always a pathological thing. You see the red arrow they have. You can see how the colors have shifted, right? So compare everything you see in here to the normal axis, which is this one. Right? So you're supposed to have this lead 1, which is the blue, the lead 2, which is the yellow. When they overlap each other, you get this purple area, which is your normal axis, QRS axis, right? Now, in a pathological person, the blue didn't change. So that's why your 1 is still pointing up over here, and it's still pointing up over here in both the normal axis and the left axis deviation. But your yellow has literally gone the opposite way, right? So now instead of the bottom half being yellow, the top half is yellow. So here, lead 2 was pointing up in a normal person, but in a person with LAD, left axis deviation, lead 2 is pointing down. And if you overlap these guys, the purple area now becomes this upper area over here, which is going to be your new axis, and that's pointing upwards. Right? It's going the opposite direction of what was normal. So the normal axis had actually everything pointing up. All three of these guys are pointing up. Now here you can see AVF is also pointing down. Right? So when you look at an ECG and you see that in 1, 2, and AVF, that 2 and AVF are pointing down, that's not supposed to happen, then you know immediately a person has left axis deviation. As we just spoke about in the beginning, the only places where things are pointing down are your AVR and V1. That's it. Those are the only two guys that have things pointing down. Leads are pointing down. And that was because AVR and V1 are on the right side of your mediastinum. Very simple and straightforward stuff. Nothing crazy to be bewildered by. Same simplicity for the right axis deviation as well. What happens in a right axis deviation is your lead 1 is actually the only one pointing down. Okay, so if I keep to the same circling, then yeah, those two guys are pointing up and lead 1 is not. So let's take a look at the right axis deviation. That's this image over here. Right, so they show you in comparing to normal. Remember that in normal, lead 1 had the blue area on the right side. Now you can see it's the opposite. Right, the blue area moved over to the left. Okay, the red area was supposed to be down at they don't have the red in this area because there are no, in this image here, they didn't put AVF. They just put 1 and 2 because that was enough to make the point. But AVF was actually supposed to be something that was more on the right side, and now it's on the bottom. And when you do the overlap with these two, you get a purple area that's pointing so far to the right side. That is a right axis deviation. That's not supposed to happen. Your actual correct AVF formation would be enough such that when you do an overlap with these two guys, so your blue is supposed to be like this. Remember, the normal blue is this one, okay? They haven't given you a normal AVF image here, but the normal AVF image would be in such a way, right, that it would be something like this, okay? So that when you overlap the two guys, you get this overlapped area right here that I'm coloring in, which is very similar to this. Okay, that's how it's supposed to be. So if I was to draw the normal AVF for you, I would draw it like, be the circle, and then it would be something like that. That would be your normal AVF. Right? So that if I overlap this blue circle and this normal AVF on top of each other, it would highlight this area into purple, right? And that would be the normal QRS. Okay, so I couldn't find an image where they had the normal AVF put into it, but here they're showing you the pathology of what happens in a right axis deviation, and then you can see how it's pointing towards the far right. And what you start noticing in comparison to the original is that lead 1 is now pointing down when it was supposed to be pointing up. Right? No other lead besides AVR and V1 should be pointing down. So as soon as you start seeing leads that are incorrectly pointing downwards, you start figuring out there's some kind of axis deviation going on. Right? So this is something that you could have been catching all along, even in your step 1 questions. But thankfully, so far, step 1 questions were never actually written in such a manner that you needed this information. However, there were times, and I started seeing that much later, even I didn't know this very well when I took my step 1, but there were definitely times that I've been tutoring step 1 students where I look at an ECG and there's stuff I can read in it that they can't tell, and then I'm like, wow, it would have definitely been nice to know. So I tend to give this little ECG lecture to pretty much all step 1 students as well, because the more you know, the better, and it's definitely very helpful stuff. And so that wraps up understanding axis deviation. You're not going to master this in your first try. You're not going to know it perfectly well on your first try either, so don't try that. Don't try to be a pro at this on looking at it once. But definitely revise this, right? Revise this table and revise your Rad-Ralph and Lad-Villa mnemonics. To memorize this table, one of the things was just remember, main one to remember is lead 1. In LAD, lead 1 is up, while in RAD, lead 1 is down. The other leads, 2 and AVF, are opposite to whatever lead 1 is doing. Okay. Extreme axis deviation I've never heard of, but it's just the opposite of normal in all directions. Everyone's pointing down. And so extreme axis deviation would be this one. So some weird overlapping would have to happen that your axis deviation actually points in this direction. I've never seen that in the question, and once you become very confident at this stuff, if you're ever doing a question where nothing adds up, nothing makes sense, and none of the scenarios look like they fit in LAD or in RAD, then you should be pretty confident at that point to pick an extreme axis deviation as an answer choice and just move on. And that can happen. That can definitely happen in step 1. I'm sure a lot of you guys, if you've all taken it, I'm sure all of you noticed that there were a good handful of questions where you had no idea which one was the correct answer choice, and you had to pick based off of your best your best knowledge. So it's not that straightforward. Let me see what's happening here. Okay, so that's fine. Alright, so that takes care of the axis deviation topic. Now let's move on to what else they're talking about here. So this set of information here, this is all stuff, again, that you've already seen in step 1. Right? So it's worth making sure that you take a look at this and reinvest yourself into it to make sure you know it. You don't want to be too confused about it. None of this should be information that comes off as possibly stuff you don't remember, right? So of course there's a good chance you might not remember some of this, but you want to make sure you know it. Then you have your second mnemonic. So we did the Rad Ralph and the Lad Villa. We looked at the axis deviations. We figured out how to look at leads 1, 2, and AVF. Let me just take this really quick. हम पढ़ा रहे हैं, मेरे कुछ काम था. हाँ फिर हम आते हैं बात करना. हम जा रहे हैं दूसरा क्या बात है. हाँ ठीक है. Okay. So let's take a look at this. Now we have this mnemonic of William and Marrow. Definitely a mnemonic you'll be using a lot. It's a very important one. So here, this is also a very nice mnemonic, very simple mnemonic to work with. It nicely shows you that a person has William and Marrow, right? So your left bundle branch block is always a person who has the W on V1 and an M on V6. Theoretically speaking, and you can see that right here, theoretically speaking, you should never really see an M on any QRS complex. And the W often tends to be the harder thing to see. In my opinion, I have more trouble actually grasping the W on a QRS complex, but finding the M on a QRS complex is actually much easier. So if you look at this example here, this is supposed to be a left bundle branch block. Right, so they said that the left bundle branch block is William. William means having an M on V6, and you can see that. You can see that little notch they have on your V6. In a right bundle branch block, that's Marrow, right? So RR for right, LR for left, right? So this one is supposed to have an M on V1, and again, you could very nicely see that, right? You could nicely capture that M in V1. These two M's look very different from each other. Right, so you can see how the V6 version of the M is actually a tiny M on the top. The V1 version of an M makes the entire QRS into an M. Okay, so they look very different from each other, but nonetheless, they both look like an M. Very, very nice and easy to catch that, right? So in the book itself, they have, again, a right bundle branch block, and immediately in the V1, you can see there's an M happening, right? So there's 4 different complexes here, so if I trace it in this middle one, it's just like that. That's your M. Okay, so you're seeing that, and then it's supposed to, because Marrow is supposed to have a W in V6, but that's often very difficult to catch. So they've drawn a couple complexes here. If I trace it for you, it's basically looking like that. That's not the prettiest W in my opinion, so it's not the easiest one to catch either. I depend more on finding the M, right? That's what I do for most ECGs. So now, always recap this, right? Always recap this. So as we initially started about visiting in ECG, we had multiple things to look at, right? We cut it in half. We did the R wave progression, right, to see how that's growing. We made sure that VR and V1 are the only ones pointing down. We looked at 2-3 AVF to see if there's any ST elevations, ST depressions, because that would be inferior MI, and it would be related to your main arteries that supply the SA and AV node. And then we looked at 1-2 AVF, right? 1-2 AVF to figure out left and right axis deviation. Great. That's all things you quickly looked at. All this is supposed to happen within like 30 to 40 seconds. You'll stop looking for more things as soon as you find enough things that can give you a diagnosis. Now we just learned William Marrow, which is V1 through V6 once again. So one of the issues with those two guys, V1 and V6, is that V1 tends to be very tiny most times, and V6 almost always points up. Right? It's supposed to, it has to. The only ones pointing down are VR and V1. So if you're looking for William, right, I said that I like looking for the M. So if you're looking for William, which is for left bundle branch block, you're going to be able to find the M here very nicely because V6 is actually really tall. So it'll just create a double thing and you'll see that M. You'll see it and you'll know someone has a left bundle branch block. But the Marrow, right? The Marrow is often harder to work with. It's actually not that straightforward to capture the Marrow design. So when you're looking for the Marrow issue to occur and you're looking for an M in V1, if it's pretty like this, you'll see it. If it's not so pretty, catching the M is often very difficult because V1 is very tiny to begin with, right? V1 doesn't look as big as they've shown you in the first aid image here. I'm not even sure if this is actually from a real ECG, but in the book itself, I've actually put some ECGs here to capture what you're going to be looking for. So let's take a look at this first one right here, right? So I'm going to make it big for you guys. This ECG was supposed to depict a left bundle branch block. So let's evaluate this ECG using everything we've talked about so far to make sure we see what we're supposed to look for. So as usual, you're going to cut it down half. Right, in the middle, you're going to look for R wave progression, and right away, before you can even start looking for R wave progression, you can already see there's a problem. Right, compared to our normal guy, which just had a tiny hill here, we've got quite a weird thing happening here. We have this first guy that's pointing up, and then all of these guys are pointing down. V1 was supposed to point down only a tiny bit. Right, remember AVR and V1 are the only two guys that point down, and it was supposed to be a tiny hill, not such a big one. So already I'm not seeing an R wave progression. Something is definitely wrong. And then we start evaluating it. So we look at it, we can see that there's something wrong throughout the entire right side. So we can pause that, take a look at what's happening on the left. We come over here to the left side, and on the left, if you're looking, 2, 3 in AVF, not really able to notice anything very abundant immediately. No, nothing crazy is happening over here. And then if you look at 1, 2 in AVF to figure out the axis deviation, well, 1 is pointing up, 2 is pointing up, and AVF is pointing up, so there's no axis deviation. That's normal axis. So then you have to see what could truly be going wrong. Right, so now coming back to the right side of the stuff, we start evaluating for the William versus Marrow. Right? And what you're basically going to be looking for is where do you see the M shape, because I personally say that finding the M is much easier than finding the W for the most part. So I wrote here that you can note broad QRS complexes, dominant S waves in V1, and the absence of Q waves in V6. Right? So V1 has your W, and V6 has the M. And how do you see that? Right? That's all that comes down to. How are you supposed to actually catch that? Because as you can already tell, I'm going to make it bigger so you can kind of zoom in. As you can already tell, this is not as clear in terms of finding the W and the M as it is in these examples here. Right? In these examples, seeing the M was super clear, whether it was in V6 or V1. Here, you can't quite entirely see it. So one of the special things that I like to employ is the idea that you also want to look for what you don't see. Right? So if you don't see an M in V1, then there might be an M in V6, and now it comes down to really convincing yourself into that, right? There's no way you can draw an M in this V1. There's no M to draw, right? There's no M to draw in V1 because V1 is actually appropriately pointing downwards. So then it's actually possible that there might be some kind of weird W here. It's easier for me to impose a W onto that than an M. And coming back to M6, it's definitely possible that there might be some kind of M activity here that just isn't very visible. Okay, but that's what's going to happen on your exam, right? You're not going to have W's and M's that are extremely clear to catch. They're not going to be extremely clear to catch. And there are other things to look for as well, but as far as our bundle branch block stuff we're looking for, it's not going to be that clear. Take a look at this next one as well. So this next one here, this one is supposed to be the other side. This is a right bundle branch block, so that's going to be your Marrow, right? So here, thankfully, it is very clear, right? As I was saying, compared to here, let me make them both equally as big so you can kind of, I'm going to hover. Okay, so if we're comparing the V1 here to the V1 here, you can instantly see that on the left one, the V1 does definitely not have an M. There is no M there, right? So it cannot be a right bundle branch block. The M is very clear on the right ECG that I'm hovering over there. Right, so let me make this small and put it away and then grab my pencil. And clearly on this V1, I can see it. I see the M. It's very apparent, right? And then if I come to V6, as I said, the W is often much harder to see, and you don't really see a very concise or clear W, so you let it be, right? But you see the M. And if you had to do it, you would probably find something like that happening to be able to identify a W. but it's usually not that clear. You know, there's going to be a dent here that goes up, comes down, then a dent there, and that's supposed to give you a very unappreciable W. But the M is far too obvious, and you can immediately catch that as a marrow design, and that's going to be your right bundle branch block, right? So that's the extent of how you're going to utilize that. That's how you're going to capture that. You're going to know this person has a bundle branch block, left or right, and then you move on from there. You pick the answer choice, and then you're done there. The other thing is working with the ischemia and infarction stuff, right? So these guys here, the ischemia and infarction stuff we talked about very similarly in step 1 as well, where it was topics about the progression of an MI, what happens when a person comes in with an MI. So if a person has an MI, one of the key things you're almost always looking for are ST changes, right? Either ST elevation, so that's an ST elevation MI, a STEMI, or an N-STEMI, which is a no ST elevation, which usually means it's going to be an ST depression MI, right? And those two things, those facts actually tell you things, right? So back in step 1, I actually made up a mnemonic for that as well. So let's take a quick look at, let's see if we can find it. Right here should be. Let me see. No. Subendocardial versus the entire endocardium. Oh, right here. Okay, it's right there at the bottom. So you can see how it kind of looks like, right? So they tell you you're supposed to look for it in V5, but you can really see it in many different complexes, not just V5. But here you see ST depression, right? The ST segment is lower than the general baseline. You're going to have a baseline, and I'm going to show you the baseline on the other full ECGs, but the baseline is basically right where the QRS started, right? So that's your general baseline, and this is below the baseline, right? That's what you're looking for. Same thing here, you have your baseline, and your ST segment is above the baseline, so that's ST elevation. So I always think of ST depression as depression, which is where you're hurt from the inside, right? In depression, the pain is inside. It's not like physical bodily depression where you have pain outside. So that's what you see in ST depression MIs, right? The N-STEMIs, which is a no ST elevation, which usually means it's an ST depression, has an infarct from the inside, only inside, right? So this is called a subendocardial infarct. Subendocardium, which is the inner 1/3, is especially vulnerable to ischemia because blood needs to pass through the entire endocardium to supply blood on the inside, right? So then that part just gets infarcted, and you see that as an ST depression. That is a depressing injury. You're hurt from the inside. ST elevation is a big injury, right? Big injury that will elevate problems, and it's a big injury because it goes through the entire endocardium. So it's transmural, transendocardial, goes through the entire wall. Right, so that's kind of what that knowledge actually begets to you. That's what it tells you. So when you start seeing those ST changes on any QRS complex, you start thinking there might be an MI. In this first one up here, we actually do see some level of ST changes, but not in the V5 guy, right? So in V5, we don't really see an ST change. What we do see is that it's not as big as it's supposed to be, right? Remember that we're thinking here, when we look at this first one, we're supposed to be thinking we have a left bundle branch block. And the reason we're immediately going to think this is a left bundle branch block is because nothing else is really wrong anywhere. And I don't see marrow. I don't see an M in V1. So I'm going to suspect this is a left bundle branch block. If you have a left bundle branch block, then the right side of the heart is going to work a lot stronger than the left side, right? So you would also suspect some level of right axis deviation. And you would also suspect that the V1 to V3 guys are going to be a lot stronger impulse than the V4 to V6. And you see that, right? You can see that, right? You see how V1 is super tall, covers almost 1, 2, 3, 4, 5, 6 different boxes. It's such a tall QRS complex that it's almost about to go into the next line. That's too long, right? V1, V2 is also super tall. V3 is actually pretty long. And then what you're noticing on the other guys, V4, V5, and V6, they're very tiny. But we just saw, when we looked at the normal QRS, that V1 was supposed to be the guy that was very tiny, not anyone else. V1 was the guy that was very tiny. So there's a chance there might be axis deviation in there. But the other thing is just noticing that, just noticing V1 through V3 are strong. Because if you look at where the leads are placed, V1 through V3 look at the right heart. right? So if a person has a left bundle branch block, their left heart is not working too well, then the right heart is going to overshoot. It's going to be, on an ECG at least, it'll be much stronger looking. And that's why that further helps you confirm the fact that this is probably left bundle branch block. Because there's nothing happening on the right side leads. The guys that are going to be looking at your, nothing happening to these leads that are going to be looking at the left heart. But the right heart leads, the leads that look at the right heart, V1 through V3, they're pretty strong, right? So this is definitely a guy with left side not working, left bundle branch block, and you just move on from there. The other thing is more things you can look for on an ECG, right? So now the next mnemonic comes up. Topics related to chamber enlargement. Okay, so let's jump right into the examples because you can read this on your own whenever you need to, but it's better to, and most important, to grasp what you see in the leads, right? So let's see the leads they show you in the book. This is supposed to be showing you here left ventricular hypertrophy. So again, you're thinking the left heart is very, very strong now, much stronger than the right heart. So immediately from the topics we've already covered, you would assume that the person with left ventricular hypertrophy would have left axis deviation. And we already talked about it, that left axis deviation is one of the things where lead 1 starts pointing up and the other two guys are going to be pointing down, right? Lead 1 is supposed to stay pointing up. That's normal. But lead 2 and AVF should be also pointing up, and they won't. They can't because you lost this area. The left heart is pointing so much towards the left side, it's working so much more powerfully to the left side that the axis shifted towards this green environment, moving away from 2 and AVF. So now 2 and AVF point downwards. So let's take a look at these. You know, they didn't give you the full ECG, but I have more further in the book for full ECGs. It's better to look at full ones. But this is just to get a point across. So what we're seeing for left ventricular hypertrophy, they're showing you leads V1, V2, V5, and V6, which is all related to your V wave, the R wave progression of your V1 through V6. So V1, we know, is supposed to be pointing down, so that's great. But then it's supposed to be pointing down tiny, not so long. Right? So you can already see this is a little too long. V2 is also too long. And the V5 and V6 are pointing up, which is also good. So what exactly are we supposed to be catching here? Well, for ventricular hypertrophy, and this is probably not something you're expected to actually do on the test, but more so pick answer choices with. Although I'll be honest, I haven't seen either things happen on the actual UWorld questions I've looked at for CK. Anyone that I've heard back from that took the CK, it doesn't happen. But it's a basic thing to make sure you can try to grasp. So what they tell you is that there's going to be the sum of things that's going to be a problem, right? So they first tell you to look at the sum of the S wave in V1 and the R wave in V5. That's going to equal 45. That's what they're saying here. That bit of knowledge doesn't really mean too much, in my opinion. It doesn't really become something so easy to evaluate, nor is it something that you'll truly be using to evaluate left ventricular hypertrophy in the clinical setting. So although they've put that knowledge here, don't let that be something that intimidates you and then makes you feel like, oh my god, I can't do this. Just take it for what it is and keep it at that. But it's not really some kind of knowledge base that I would say is critical to know. The more obvious thing to actually catch here is the fact that the lines are not coming back to baseline. Right? That's what you should really start seeing here. So if I draw the baseline for you guys here, let me grab my line. So you can see how, you're going to notice, very apparent here, if I draw this baseline, you can see that the ST didn't come back down. It was supposed to be baseline, but it's kind of got this like hump kind of thing happening over there. And it's even more off baseline on the further right one. Okay, same thing here too. This is your baseline. You see how your ST didn't come back all the way? Right, so there's definitely ST changes that you're going to immediately start using to think, okay, this person might have had an MI, either subendocardial or transmural, doesn't matter. An MI is an MI. You start giving the patient the treatments they need to have for their MI. And eventually put them in the cath lab and catheterize their hearts and take out anything that you need to, right? Put stents in wherever appropriate. But some of the more actually appealing things to catch are the atrial enlargement things, okay? So left ventricular hypertrophy, not so good, not so easy to catch, and thankfully not really something clinically used either, because if you look at what they teach you for left ventricular hypertrophy here, look at it. There's a couple things. You could either look at the S wave in V1 and add that to the R wave in V5 or V6, and it should be more than 35, which is what they're showing you here. that numerology is stupid. Just think of it like this. If V1 and V6, the first and last guy, are actually both really, really tall, your left ventricle must be really big. Right? That's left ventricular hypertrophy. That's all that really means. If the sum of the numbers are more than 35, that basically means V1 and V6 are very big. Okay? So if V1 and V6 are very big, both of them, then that's partly making you think left ventricular hypertrophy. And look at the sensitivity and specificity. Not that good, right? Sensitivity is for ruling things out, so you can't rule anything out with this, so it's not going to be a screening test. Specificity is for ruling things in, which is pretty diagnostic. 85% is good, but not the best. So then you have this alternative criteria. The alternative criteria is to look at the amplitude of the R wave in AVL and the S wave in V3. Now sure, let's assume this might be something easy to do, but how are you going to remember this? Right? There's no way to really effectively remember, oh, look, let me look at the R wave in AVL and the S wave in V3. It's really annoying. That's not something that's going to work so well. And on top of that, there's different criteria for men and women. Once again, this isn't exactly something that has high sensitivity. It's a little better than the first thing, but specificity-wise, it's pretty big. So it's definitely something that could possibly be diagnostic. But all in all, and I'll be honest about it, left ventricular hypertrophy is not something you really diagnose just based off of these basic things, right? There's if you ever have a question on these things, hopefully there's going to be a little more about it than on your actual question stem, and you'll have some more information to base it off of, right? Left ventricular hypertrophy. So don't worry about that stuff too much. Don't worry about this stuff too much at all. I've personally have yet to really use it on any practice question that I've done with any students, so don't worry about that. This has shown up though, the atrial enlargement stuff. Atrial enlargement stuff has shown up, and it's kind of very similar to the William Marrow stuff we were looking at, because once again you'll be looking for the M's and W's, and thankfully they're pretty apparent. So you could either have right atrial abnormality, which is a right atrial enlargement, which would happen in a person who maybe has pulmonary hypertension, right? So they call this P pulmonale. The P wave amplitude in lead 2 is going to be very tall, right? So you can see that, right? Normally you would look for a tiny P wave, and then you have your big QRS, right? That's what you look for, and then you get your T. The P is almost equally as tall as the QRS complex. That doesn't happen. You don't get a P wave that's also equally as tall as your QRS complex, right? That looks very abnormal. You can see how your P and QRS are looking almost the same height. That's not very real. So when you start seeing that, you think of P pulmonale, P wave is too high, and you start thinking right atrial abnormality. Pulmonale being the fact that it's something related to right side. Just like cor pulmonale, back in step 1, cor pulmonale meant you had just isolated right heart failure. Okay, so P pulmonale is telling you that you have right side atrial abnormality. Left atrial abnormality is known as P mitrale, which might be due to left atrial pressure being high. Maybe the PCWP is also high. What you notice here is that the P wave in lead 2 is going to be very long. It's going to be having a very wide lead 2, and you start noticing these notched P waves that can frequently be seen in lead 2 as well. So once again, the notching creates something of some sort of an M, as you can see right there. So let me make that one bigger. Right click on. So if I make this image bigger, you can kind of see that, right? The P mitrale, what you're seeing is two things. One, you're seeing the fact that the P wave has this M-shaped kind of thing happening there. That's a mitrale. That's telling you that there's some kind of left atrial problem. Remember that the P wave was actually due to atrial contraction, right? So if you have an issue with atrial contraction, you want to start thinking of what might have been causing it, okay? If you have a mitrale thing happening like this with the M sign, and you can keep seeing it, it happens in the next one and the one after that, that's a sign that you have left atrial problems. If you have a P wave that's super tall, that is a right atrial problem, and that would be your P pulmonale, okay? So not so bad. Obviously, you look at your P wave for your atria, and that's what we're learning here. Right, so this table here kind of summarizes some of those things we've looked at, right? You have your normal lead 2 and normal V1. That's just how they look. V1 does point up, and V1 is tiny, okay? Then you look for right atrial enlargement, your left atrial enlargement, and right atrial enlargement, we just said, is where you have your P pulmonale, which is basically a P wave that's very tall, right? And that's what you're seeing there. With your left atrial enlargement, that's called P mitrale, and you look for an M, and you can clearly see the M here, right? And your lead 2. If you have both, that's something that's almost never really going to be a question, because if it is a question, if you have someone who has atrial enlargement on the right and the left side, then an ECG alone is not going to be diagnostic enough, because as you can see, both of these look very similar. There's actually no difference. It's the only difference you're seeing here is the fact that one is more accentuated than the other, but on your step 1, you're not going to have one to compare to another, so you're not going to be able to see how accentuated it is. So they won't do this to you. Don't worry about that part. But just understand, left atrial enlargement, P mitrale, the P wave, this is just showing you the P wave. This is a normal P wave, a tiny one, then you're going to have the QRS, right? So they're only showing you the P wave here. Normal P wave, right atrial enlargement has this weird P wave that's going to be too tall, because then you're going to have the QRS complex and it's almost equally as tall. That doesn't happen. Shouldn't be that tall. With the left atrial enlargement, mitrale, you get a very clear M. Okay, so don't be too confused about it. You do get something that looks like somewhat of an M in the right atrial enlargement as well, as you can kind of clearly see that you can write an M over that, right? But what you're going to notice is this is going to be too tall. It's going to be too tall. So the more concerning factor is how tall is it, right? If it's a very tall P wave, that's P pulmonale for right atrial enlargement. If it's an M-shaped P wave and it's not very, very tall, that's a left atrial enlargement. That's your P mitrale. Mitrale M, easy to catch in that manner. Okay, it's not so bad. Then you have, from here onwards, things that you're going to see about cardiac exam. Okay, one thing that a lot of people tend to often get wrong is the fact that you can get a question. Okay, you can literally get a question about the mitral valve, right? Mitral valve is an extremely high yield topic to have questions on. Okay, perfect. So when you have this apartment M mnemonic, right, APTM, that mnemonic is showing you where you would hear your normal valvular sounds going to. Okay, that's where they're going to. But then you notice these signs, right? These signs in the middle here, okay, related to, again, valves. If you get a question where they're telling you they hear something on the left sternal border around the third rib, right, that could be a pulmonic problem or a mitral problem. And most people almost always pick a pulmonic problem because they remember the P that's right there on the left sternal border around the second or third rib. And they also remember that that's just where you would look for things. And they remember that the mitral stuff is on the mid-clavicular line further down, right, all the way over here. That's not true. That's not how that works. Okay, so don't fall for that that pretty common mistake. Honestly, a lot of students have been messing that up, and I actually entirely blame the image for being in that manner. Right, so Amboss had a similar image as well, where they kind of show you the flow vectors, because that's what's actually important. The reason you hear things is because of the flow vectors, the directionality of where things are going. Okay, that's fine. And they give you this image, and they tell you where you're hearing things. But if you look more closely, the left sternal border, which is right here, labeled, left sternal border has a couple sounds to it, right? You have your aortic regurgitation, also on the left sternal border, pulmonic regurgitation, also on the left sternal border, and your systolic murmur of hypertrophic cardiomyopathy, same area, right? So this could be due to either pulmonic or aortic or your mitral valve issues, right? Because you see the mitral color is right there as well. So the placement of a murmur alone is not ever actually enough to pick an answer. Okay, be very careful of that. Right, there are things called flow murmurs, which are physiologic. You're gonna hear some other murmurs as well. And in my book here, throughout the various questions that I put here, like you have this venous hum thing. Right, there's gonna be a bunch of new things that you might have never actually heard of that you do need to be pretty confident with. Right? You need to know how they're happening, what they mean, what they're found in. Just make sure that you don't use this as a diagnostic tool. Right, so just because they said they heard a certain murmur in a certain location, it's not enough for you to pick that answer choice. There has to be a couple more things happening, either because of the physical exam, maybe where the murmur radiates to, etc., etc. And there are a bunch of resources like easyauscultation.com, The Amboss itself has many demonstrations for each of the heart sounds, and then this YouTube link right here for great animations and explanations. All of these are different places you can go ahead and check it out. When you look at the recording later, you can pause here and then type this in to find this video. But these are very nice videos that when you're, maybe on the treadmill or something, worth listening to and worth checking out, right? And then over here in your annotated CK book, I've put in the links for each of these murmurs and how they're supposed to sound and how you're supposed to examine them, because Amboss made very nice videos of it. Okay, so Amboss made videos where you have the patient laying there and then they keep moving the stet into different locations, and they also put it on the neck, and you get to hear how it sounds in each of those locations. So totally worth checking those out. These are audible things, so the more often you listen to them, the better you get at identifying them. This cannot continue to be something that you're intimidated by or feeling iffy about or just not that confident with, right? Of course, no one was good at this in the beginning. It's also something you get better at the more you listen to it. And you have to be able to combine the sound with the knowledge of whatever information they might have given in the question stem about the patient himself or herself, okay? So make sure you have that knowledge down very well. And keep in mind that, everything from S1 to S2, lub-dub, this happens within a second. So you have to essentially get so good at this that you have to be able to slow down what you hear so you can actually capture the murmur. Okay, otherwise it's happening too quickly. And to the untrained ear, these lub-dubs are the quickest thing ever, faster than a second, and it doesn't help, right? It's not effective for them. So that's how you get good at it. The more times you essentially train yourself to listen to it, the better you get at it. The other thing is this mnemonic I had come up with, D-arms. I made that up when I was teaching step 1. D-arms is to remind you that your only real diastolic murmurs are your aortic regurgitation and mitral stenosis. Okay, those are the only diastolic murmurs you're concerned with, and of course whatever is equivalent of it on the other side, right? So that's what I wrote here, D-arms, like your dining arms. So diastolic is aortic regurgitation or mitral stenosis. So if you get a question where they're literally talking about a systolic murmur, a murmur that occurs when your ventricles are contracting, it is not going to be one of these guys. Okay, because if your murmur is occurring when your ventricle is contracting and it involves the mitral valve, then it's going to be mitral regurgitation, which means that when your left ventricle is contracting, blood went backwards through the mitral valve back into the left atrium. And that's going to be up here, mitral or tricuspid regurgitation. That is a systolic murmur. That murmur of mitral regurgitation can only occur during systole. Blood is not going to go back up the mitral valve into the left atrium during diastole because it's actually coming down from the left atrium. So D-arms is a very nice mnemonic to help you knock out at least an answer or two when you're answering some of these questions. And that's what you want to spend your time on. You really want to make sure when you're examining these questions, what it was in the question that specifically helped you figure out the most likely answer choice. Now, Amboss does a good job of doing what the actual CK does and what real patients do, which is they come in and they tell you their life story. Look at how big this paragraph is. The same thing is going to keep happening over and over. When you start doing your CK questions, it is very rare to get a small question like this. And if it is a small question, I usually get scared because it's going to be about a topic you might have never heard of. Like this question was actually something I had never heard of, which is the venous hum that you can hear in pediatrics of a 4-year-old girl. It was really annoying, right? But it's all part of learning. Otherwise, most questions are going to be very lengthy and tedious, right? And that's what you're seeing for the most part. So, spend some time making sure you revise, right? That's what we want to do on this first day. We gained a bunch of new things, which was your ECG reading tools, right? You have your William Marrow, your Rad-Ralph and Lad Villa, right? You have your P pulmonale, P mitrale, looking for the M in Marrow and the M in William for V1 and V6 and stuff like that. All of those different things. Your R-wave progression that we talked about. You learned a lot of things about mastering how to read an ECG, such that if I give you any ECG, you'll know at least right now, if this is your first time ever doing this, at least right now, you know what you're looking for. You might not get the perfect diagnosis right away, but you know what you're looking for. And you might have a good list of top 3 possible diagnoses, which actually is a great place to start. right? So that's great. Make sure you know those things. Make sure you can see that on the various ECGs. You should all have this book, and if there's any questions, anything whatsoever, feel free to reach out. But you should have the book, go over it, and then go over these questions and check out these murmurs and revisit first aid step 1 in case there was anything that you have now maybe sort of forgotten and need to brush up on. Okay, so we'll stop that at here for today because this is actually quite a bit. After that, we're going to be moving into, just looking at a little bit more of the heart murmurs, and we're going to go into arrhythmias. And this is where the real bulk of CK stuff kicks in. We're going to do this on Wednesday, where we're going to look at different scenarios of things that occur and then figure out what it is that you're supposed to look for in a question to know exactly, okay, this is his problem. This is exactly what the patient came in for. And then understand the next best step in treatment, next step in management. Management can include one or two things, either actually giving treatment, or management can include doing an intervention or doing another test to further check maybe the severity of a problem, or maybe whether or not it is exactly this problem or a different variation of the same problem, right? So management can include many things. Now, something special I have done for cardiovascular, because I was doing this in preparation for these lessons, was that at the end of the chapter, I had this list of things that summarizes everything that is discussed in cardiovascular. Right? So today, we knocked out this topic, right? We talked about all of these guys, okay? And then we've practically revised most of these things, but the things in cardiac physical exam that you have now forgotten, because these are all step 1 topics. Everything in cardiac physical exam that was in CK book is these things, and these are all step 1 topics. So if there's anything here that you've forgotten, maybe never heard of, maybe don't understand or don't know of, go ahead and revise that today, okay? And then feel free to email me about that. And then in our next session on Wednesday, we're going to go through and wrap up how to deal with arrhythmias, how to deal with congestive heart failure. 2 massive topics about cardiovascular, okay? And on that day, we might take a little break in between, then come back to it and wrap up more of this, like the cardiomyopathy, coronary artery disease, and acute coronary syndromes. None of these are actually that lengthy and difficult or intense, so we might actually get through quite a bulk of those things in the next session. So we're going to leave it at that for now. I'm going to go ahead and upload this video onto a playlist, and then I'll email all of you the playlist and add you into the videos so you can watch it on your own leisure, especially if you missed the beginning or missed the lecture overall. Thank you very much for joining, guys, and I'll see you guys again on Wednesday. I'll email everyone about the next meetup.